For primary care physicians, skin and soft tissue infections are what we call a bread and butter complaint, accounting for 6.3 million physician office visits per year in the United States. 95% of skin and soft tissue infections are managed in an ambulatory setting. Among medical diagnoses, infections have the unique aspect of local resistance rates influencing our approach to treatment. So, while national guidelines provide a broad framework and serve as a helpful starting point, it's important to tailor treatment to the populations in question. In this project, we aim to improve the appropriateness of empiric antibiotic selection for skin and soft tissue infections at the OSU Healthcare Center by developing and implementing a clinic-specific antibiogram by July 1st, 2026, with evaluation of prescribing patterns pre- and post-implementation. Our methodology was based on a retrospective review from January 1st, 2021 to December 31st, 2025, examining methicillin-resistant Staph aureus and methicillin-sensitive Staph aureus specifically. Based on chart review, percent susceptibility was calculated for commonly used antibiotics to generate a site-specific SSTI antibiogram. 62% of Staph aureus isolates were MRSA, which is a notably high prevalence compared to national community averages. This reinforced our decision to use empiric MRSA coverage in the form of doxycycline as first line. The starting point, the algorithm that we developed based on the percent susceptibilities, is determining whether there is a drainable abscess or not. If there is a drainable abscess, we proceed with an incision and drainage. Per the Infectious Diseases Society of America, systemic antibiotics are indicated for fever, tachycardia, impaired host defense, multiple infection sites, rapid disease progression with cellulitis. If we do proceed with antibiotics, we treat to target MRSA. Bactrim is listed as an alternative rather than first line here due to lower susceptibility compared to our first line pick of doxycycline. If there's no drainable abscess, we assess for whether MRSA coverage is indicated, looking at factors such as purulence, IV drug use, history of MRSA colonization. If the MRSA coverage is warranted, we target MRSA with doxycycline and beta hemolytic strep with beta-lactams. Once again, we have listed Bactrim as the alternative treatment. If there's no drainable abscess and there are no risk factors for MRSA, we target beta hemolytic strep and MSSA with Keflex or cefadroxil. Clindamycin was not included for MRSA coverage here because there are higher resistance rates, and while it has good susceptibility for MSSA and strep, there's an increased risk of C. diff infection that needs to be factored in when prescribing, and we have listed it as an alternative rather than first line. Bactrim is also listed as an alternative again because beta-lactams have higher clinical efficacy and a better side effect profile. In terms of study limitations, the extended time frame that we examined might actually mask emerging resistance trends. Our total sample size was 52 cases, which is not uncommon for outpatient antibiograms. However, CLSI recommends a minimum of 30 isolates per species for reliable data, so our MRSA group met this with N equals 32, but the MSSA group did not with N equals 20, so the MSSA data should be interpreted with a degree of caution. All in all, the antibiogram supports empiric selection in treating skin and soft tissue infections in our ambulatory clinic and should be used alongside clinical judgment, patient-specific factors, and culture results. Now that we have this antibiogram and an algorithm to help guide treatment selection, the next step in our longitudinal initiative is moving forward with actually promoting appropriate empiric antibiotic selection in our clinic. The results of this antibiogram will be provided to our prescribers with postings in our workspaces and departmental education sessions. Baseline prescribing patterns will be evaluated and compared to a post-implementation analysis to assess how the antibiogram data impacts our clinic-wide empiric antibiotic selections and antimicrobial stewardship outcomes related to skin and soft tissue infections.